Hello to everybody who's connected to the PCR webinar, Mastering TAVI in Severely Calcified Aortic Stenosis with the LOTUS Edge device. My name's Wolfgang Rottbauer, I'm coming from Ulm. Let me lead you through the agenda. So you see it here. We will start the session with a case presentation with a severely calcified aortic valve. We will learn something there on calcium quantification. Then we will move on to the implications of paravalvular leak, permanent pacemaker implantation, and annular rupture in the context of treating severely calcified aortic stenosis. Then we will learn in another talk something about protected TAVI, especially in complex situations. Then we will show you, after the case presentation, the treatment results, and we'll try to discuss that with you. And in the end, we will give you a quick overview over the new Respond Edge registry and the outcome of the first 50 patients in this registry. So the learning objectives of our webinar are summarized here. We would like to increase your knowledge on how to master severely aortic stenosis. We want to understand together with you what might be the implications of heavy calcification on treatment results regarding paravalvular leak, pacemaker implantation, and annular rupture. And in the end, we might want to learn something about how to protect the severe complication of TAVR, the stroke. Finalize here with the panel. You see the four faces here already on the screen. On the right side is Sonia Petroni, my co-chair. She's from Pisa, Italy. There's Daniel Dagman on the right side now on the screen from Leeds, UK. And we have Dr. Damentel from Toulouse on our panel. So with that, I think the introduction is done. And I give over to Sonia Petroni. She will introduce now a very nice case to all of us for discussion.
Thank you, Wolfgang. Certainly, I will begin with a discussion on the CT evaluation for calcium calcification. You will see that in this case, it is very important. We have a man of 81 years old with hypertension, dyslipidemia, COPD, and obesity, and he was admitted for an acute episode of dyspnea, a good ejection fraction, a severe aortic stenosis, a very high gradient, and no conduction disturbance at the ECG. You will see now here at the 3-Mansio the reconstruction of the valve with the calcification mostly of all the three leaflets of the valve. And to be completed, this is the Agostone evaluation with no contrast, which is the typical way that in general calcium is evaluated. To sum up the calcium in this particular patient, we can say the calcium volume was high. And I can say that even for the European guidelines, it would be severe aortic stenosis for the amount of calcium. There was no calcification in the LVOT, which is something important. No other horizontal aorta or other things to describe for this valve, and a good takeoff of the coronary ostia. You can see here the perimeter and the area of the valve and the annulus area derived diameter, which is around 25.6 millimeters. And you can see, as I told you, that the distribution of the calcium was mainly on the three cusps of the valve. The aorta and the femoral arteries were quite large, good diameters and good low bifurcations of the femorals. It is very important, as I was saying, how to quantify correctly the calcium, because sometimes we are used to the Agostone score, but we generally are used to measure and see the calcium with a contrast dye in RCT, and this can make a difference. because depending on the ratio that you consider, as you can see in this slide, you can have some bias, and you can judicate calcium too much depending on whether you put your cut off for the evaluation. Another point is that with the normal CT, with the angio-CT that we do, we are able to care and to evaluate the distribution in the valve of the calcium, not only the quantification on the valve. And this can be very important to take some decisions or to think if there will be some or any complications. We just show you this nice work, but we will talk about it later, that there are some relation with the calcium and with, for instance, the distribution in the LVOT, but luckily this was not the case for this particular patient that we are considering now. So I, at this point, would like to discuss and a question to all of you. So please answer. So which valve would you prefer with this patient with a heavy amount of calcium, no LVOT, calcification? Would you put a self-expandable valve with perhaps a predilatation? Would you consider a balloon expandable valve? Or would you consider a mechanical expandable valve with the choice of using a predilatation or not using a real predilatation with a balloon? I would like to hear what Dan thinks about it. I mean, what would you really do about it? What valve would you choose?
Thanks, Sonia. I think you've made the key distinction there when considering heavily calcified anatomy between calcification involving just the cusps, as we see in this case, and calcium that also involves the LVOT. I think when the LVOT is involved, that's where my primary concerns will be over avoiding any risk of annular rupture. That means avoiding balloon inflation at any time during the procedure, particularly during valve deployment or post-dilatation. So with LVOT calcium, I'll be steering away from a balloon expandable valve, and I'll be looking for a valve that minimizes paravalvular leak, which will also enable me to avoid potentially hazardous post-dilatation. But this case is really one of severe cusp calcification, and then the annular rupture is less of a concern, and we're focused on a valve that will minimize paravalvular leak and which has adequate radial force so that the valve will expand adequately to deliver good forward flow hemodynamics. So I think I'd distinguish less between the types of valve necessarily. We could use a self-expandable, balloon expandable, or mechanically expandable valve here, but we're looking for a device that's going to offer minimal risk of paravalvular leak and a device that's going to have adequate radial force to expand the valve properly.
Oh, well, then, Nicholas, would you add something? Do you think we should care of something else over annulus rupture that Dan has pointed out in his answer?
As Dan mentioned and summarized, looking at this very calcified anatomy, I would primarily think about all the complications I could expect or anticipate during a TAVI case and choose my device trying to avoid them, and choose my strategy more than my device trying to avoid them. So Dan summarized the risk of a PV leak, of annular rupture. We also can think about the risk of permanent pacemaker that is higher in such highly calcified. And I would also think about the risk of stroke and try probably to adapt my strategy thinking about that.
Well, this is very interesting. I think that, Dan, at this point, you should really, really sum up all of the potential, all the risk, and all the attention that we should make with this kind of situation. So please, can you tell us about particular complications and what can we do about it?
Okay, Sonia, that's great. If we can move forward to my first slide. So I'm going to talk specifically about the issues of annular rupture, paravalvular leak, and pacemaker implantation, which, as we've already heard, are highly relevant to the anatomy that Sonia's shown in her case. So what about annular rupture first? I think we all recognize this as the most catastrophic complication and feared complication of TAVI. These are data from nearly 28,000 TAVI cases from multiple European centres looking at the incidence and outcomes of emergency cardiothoracic surgery. And you can see that annular rupture was the second most common cause of emergency surgery at just over 1 in 5 cases, and importantly had the worst outcome, with 62% in-hospital mortality. And remember, these are the patients that make it to the operating theatre, and those that don't, the outcomes are even worse. So what are the risk factors for annular rupture? Calcification of the LVOT is the single dominant factor which predicts the risk of annular rupture. In this analysis of 31 consecutive cases, there was an 11-fold increase in the risk of annular rupture with moderate or severe LVOT calcification. But importantly, cusp calcification or annular calcification alone did not predict any increased risk of annular rupture. So that's why I commented that in this case, annular rupture is less of a factor. This slide, sorry, let me go back, showed 33 cases of balloon expanded prosthesis, annular rupture, and again showed that the dominant factor was LVOT calcification, particularly when it was present in the upper part of the LVOT and more so in the non-coronary cusp. But again, no association with cusp or annulus calcification and annular rupture. So when do we rupture the annulus? It's when we inflate a balloon. These are more recent data, again, looking at LVOT calcification. This is a recent registry from the Bern group of over 1,500 consecutive cases. And they looked specifically at the incidence of LVOT calcification and the outcomes. It's worth noting that this is not a niche issue. A quarter of patients in this study had moderate or severe LVOT calcification, defined as one nodule extending more than 5 millimeters into the LVOT or more than one nodule. And they had annular rupture incidence in this group of over 2% compared to 0.3% in those with none or mild. And again, the outcomes were appalling with 70% in-hospital mortality. So we go on to the next slide looking at when it occurs. It's when we inflate balloons. So these are data that are unpublished but submitted from 4 UK centres over 4,000 cases. And they showed that they looked specifically at the relationship between balloon inflation and procedural mortality. There were 38 cases where mortality was attributed to the valve procedure. 12 of those were due to annular rupture, and all were related to balloon expansion. 5 balloon expanded deployment, 5 post-dilatation, and 2 pre-dilatation. No annular rupture unrelated to balloon expansion. If we look specifically at valve types in relation to annular rupture, these are the Bern data again, and see in the red rectangle, I've highlighted the 3 different types of valve. And as we've seen, balloon expandable valves have by far the greatest risk. And 4% of balloon expandable valve deployment, that's 1 in 25 in moderate or severe LVOT calcification, caused annular rupture. Remember, that's mainly fatal. With self-expanding valves, it was much less common, only 1 case related to post-dilatation. With a mechanically expandable LOTUS valve, there were no cases of annular rupture, even with moderate or severe calcification of the LVOT. What about paravalvular leak? These data, again from Bern, show the association of calcification and paravalvular leak, moderate or worse. On the left, we see that the worse the calcification of the annulus, the higher the incidence of significant leak. On the right, the same applies to LVOT calcification. More calcification, more moderate or severe leak. Again, as with annular rupture, LVOT calcium appears to be particularly highly predictive of paravalvular leak. A much higher risk, 5-fold with moderate or severe LVOT calcification, still significant but less important with annular calcification. What about if we look specifically at the LOTUS valve that we're discussing today? These are data from the REPRISE 2 extended cohort, and they showed again calcification, an important and independent predictor on multivariate analysis, particularly of the LVOT, where there was a 3-fold risk of mild or worse paravalvular leak. a trend but not significant increase in risk of leak with leaflet or annulus calcium. So calcium predicts paravalvular leak. How do we avoid paravalvular leak? Well, we know if we look at valve choice, that the LOTUS valve is consistently associated with the lowest incidence of moderate or severe paravalvular leak, less than 1% in all published trials, compared to significantly higher rates with all other valve families. And if we look at this analysis of the REPRISE 3 trial, where they did subgroups according to calcium burden, you can see on the right that LOTUS beat core valve on paravalvular leak in patients with low calcium burden. But if we look specifically at those with high calcium burden, there was no increase in moderate or severe paravalvular leak with LOTUS, which still was less than 1%. Whereas with core valve, we're now seeing the rates of paravalvular leak close to 15%. If we look again specifically left ventricular outflow tract calcification from the Burn Registry, and again, if you look at the bottom panel on the left in the red rectangle, you can see that even with moderate or severe LVOT calcification, there was only one case, 2% of the total, with LOTUS with moderate or worse paravalvular leak, and this compares to 7.4% with SAPIEN and nearly 13% with the self-expanding family of valves. What about permanent pacemaker implantation? I think it's fair to say that there are other factors that are more important in predicting the risk of permanent pacemaker, specifically pre-procedural conduction and right bundle branch block. We know the length of the membranous septum, as in this study, is a predictor. But if we look across a range of studies I've summarized for you to here, we can see that with all valve types, calcification also increases the risk. So this study with the SAPIEN 3 valve, if we look again at the next slide at this study with Accurate Neo, LVOT calcium, again a multivariable predictor. A study including both SAPIEN and core valve, cusp calcification, a multivariable predictor of pacemaker. And finally, if we look specifically at LOTUS, we can see that LVOT calcium specifically was associated with an increased risk of pacemaker. How can we avoid a pacemaker? Well, if we look at valve choice here, we know that LOTUS, certainly the first iteration of LOTUS, was associated with the highest pacemaker rates, consistently over 30%, much lower with the other families. But there are encouraging signs with LOTUS Edge. Firstly, if I just show you these data, looking at the high calcium patients, again, pacemaker rate over 30% with LOTUS compared to 15% with core valve. But when we look at LOTUS Edge, that's the device we've got on our shelves now, we start to see much lower pacemaker rates. Firstly, these data showing that as we introduce the depth guard technology, allowing consistently higher implants, the pacemaker rate fell to 20%. When we combine that with the Edge technology, we're down to below 15%. We know from these data from Wolfgang and Joachim Wöhler's group in Ulm that depth of implantation is a main predictor of pacemaker rate. And once we get down to 4 millimeters below the annulus or less, we see pacemaker rates in Ulm of 15%. The same message was shown from the Atlanta group, where progressively higher implantation techniques resulted in progressively lower pacemaker rates. Once the Atlanta group aimed for 2 millimeters below the annulus, they saw their pacemaker rates fall to 15%. So if I can summarize, left ventricular outflow tract calcification is the dominant predictive factor of catastrophic annular rupture. If you want to avoid this in these patients, you need to avoid balloon inflation, particularly high pressure balloon inflation during valve deployment or post-dilatation. For paravalvular leak, LVOT calcification is a big predictor, but annulus and cusp calcification, as in the case we've seen from Professor Petronio, also predict an increased risk of paravalvular leak. With the LOTUS valve, we can minimize the risk of annular rupture, minimize the risk of paravalvular leak, and importantly, therefore, the need for post-dilatation. And I think clearly, for me at least, it's the valve of choice when there's severe LVOT calcification. Pacemaker risk is also increased in calcified anatomy and is higher with LOTUS, but is falling with progressive iterations in technology and implantation technique. Thanks for your attention.
Terrific. So I think
So we're going to move straight on. Sorry, Wolfgang. And apologies for some delays in slide transitions there. But I've covered there 3 of the main complications we see with calcified anatomy. But what I haven't covered so far is stroke, which I think really matches annular rupture in terms of the disastrous effects for the patient and for the whole team. So Wolfgang, sorry, I'm going to hand on to you. Wolfgang is now going to talk to us about the impact of calcification on the risk of stroke and where cerebral embolic protection comes in patients such as the one we've seen from Professor Petronio. Wolfgang.
Oh, thank you, Dan. So I will now focus on protected TAVR, and I will give you some ideas about complex anatomy and when you should use it or where you shouldn't use it. What you see here on the first slide is that we almost consider today the TAVR procedure as standard of care for severe aortic stenosis because we have an advantage in MACE rates regarding death or disabling stroke. But when you look a little bit closer at the outcome of these trials, you see that even in TAVR, although the stroke rate is lower than in surgery, there's still a highly significant number of strokes observed in this patient population. So stroke is a major issue during the TAVR procedure. And what you see here is that this type of stroke risk is not really correlating with the surgical risk. So a low-risk patient has also pretty high stroke risk during the TAVI procedure, similar to a patient with a surgical high risk. So you have to protect all those patients if you want to get rid of these complications. The other thing you see here is that the stroke risk is not dependent of the valve we are using or the implantation technique. So stroke occurs independent of the valve we are using during the TAVR procedure. So on the third issue that's really important is never say that you're very experienced and you never see a stroke when you treat a patient with a TAVI. Stroke is not experience dependent, as you can see here on this slide. But, and I think that's important, we know that from all our patients we treated so far, stroke is really a mortality relevant complication, and it gives you about a 4 to 6 times increased rate of mortality in the patients that suffer from stroke during the TAVR procedure. When we now look at the time points when the strokes occur, and you see this here, it's from the Sentinel trial, a protection trial. On day 1, we have about 50% of the strokes and also the major strokes, but there's still a remaining stroke risk on day 2 and day 3. So it's peri-procedural. And if you want to study effectiveness of protection, you have to consider these time frames to be safe, that you have an advantage for your patients. So overall, I think there's clearly a need that we address the issue of stroke during the TAVR procedure. And I think most of you are familiar with the different strategies. And usually today, mechanical protection systems are used, such as on the left side of this slide, the Boston Sentinel system, a 2-filter system that it's covering the brachiocephalic trunk and the left carotid artery with a filter system during the procedure. But also consider that this type of peri-procedural stroke prevention device is just in place during the procedure and not on day 2 and day 3. So here you see a small, let's see if I can, slide moved. Sorry about that. Here you see a small meta-analysis basically based on the small Sentinel trials, the Clean TAVI trial and the Sentinel trial. You see that in the lower column. And you see there, there's for sure some advantage of using a cerebral protection in preventing stroke in patients, but it's not statistically significant yet. And these results from 2017 basically led to the initiation of single registries, one here in Ulm, one in Rotterdam, and the other from Cedars-Sinai in New York. And what you see here, these are basically patient-matched analysis that we see overall, the cohorts that were treated with protection, about a 70 to 80% decrease in stroke rate in these patients. But still, this is not really a randomized trial. And what we did here in Ulm, you see the Sentinel Ulm numbers. We took 843 patients, combined them with the clean TAVI patients, 100 patients, and the Sentinel trial, and then propensity matched all these patients again regarding to valve type, to STS score, atrial fibrillation, gender, diabetes, coronary artery disease, and peripheral artery disease. And when you do this combination and have the power of a high patient number, then you can see that you can statistically highly significantly reduce all procedural stroke rate by 65%, mortality of stroke by 66%, and disabling stroke even by 84% in this type of patient population. So there might be some benefit of cerebral protection, but still these are data that are not randomized. And I think the community needs these randomized data. And you see here a slide that's outlining the protected TAVR trial. This is chaired by Martin Lian. And this trial will include in a randomized fashion over 3,000 patients, either protected or unprotected. And I think the big issue is in this context, the neurological systematic evaluation of these patients before and after the TAVR procedure. And this is just in the process of getting started. And I think we have to wait to see this data then in the end. So this is the general data on protection in TAVR, but what about complex anatomies? And I showed you some anatomies where we think or where the data is pointing out that there is a higher risk of periprocedural stroke, such as in porcelain aorta, in heavy calcified valves, in bicuspid valves, or in valve-in-valve procedures. But the data I showed you so far didn't pay attention to these risk factors and is basically referring to all TAVR patients that were protected. So from these data, you might say that this patient population, for instance, valve-in-valve patients might have a higher risk of stroke and you protect those, but you could equally say you have to protect them all. Regarding complexity, does different valve types go along with different stroke rates? I showed you that before in clinical registries, we didn't see a difference. And we did here a sub-analysis of debris that was captured with the Sentinel system in the Ulm study. And what you see here for the Boston LOTUS valve, we had the less amount of object covered or captured by the device, whereas we had with the core valve and the Edwards valve more debris in the filters. But still, when you bring that then to the sub-analysis in a matched fashion, we saw basically the same stroke reduction throughout all the valve types we implanted. So even for the SAPIEN 3 and the Medtronic and the Lotus, we had stroke reduction rates of about 70% if they were protected by the Sentinel system. So what about complex anatomy on the vascular system? You see here kinking and tortuosity. And when we started with the Sentinel system, we thought this is not a good idea to put in here a filter system, or it might be very challenging. And the same is true for the bovine arch, but I give you just here the slides. You don't have to be an expert. Anatomies like that are quite well also covered with cerebral protection and the Sentinel system. So it's doable, and there is not such thing, such a complex anatomy for cerebral protection. Overall, and this is just the summary, today you're able to put in, at least in 99% of the patients, a protection system very safely and efficiently. In 95% of the patients, you can place at least one filter, mostly on the truncus, once in a while also only on the carotid. It takes you about 4 minutes of procedural time going from the radial access to putting the Sentinel system in place. So, and in the end, I think I want to be a kind of little bit provocative for this session. And I'm summarizing like that according to the data we have so far, although they are not randomized trials and large, all TAVR patients might be considered for being treated with cerebral protection, not only the patients with a very high risk of stroke, but also the ones with a lower risk. And I think we are able today, and everybody is that, to put it in even complex vascular anatomies. So with this, I think I want to end this kind of topic, and I'm kind of lacking the randomized data. And Sonia, you're kind of smiling because we are coming back to your case, but I think we want to discuss on your case first the result and not if you use protection or not. So please go ahead, show us your beautiful case.
Okay, thank you very much. So we go back to our case, and it's exactly the same patient with the CT I showed you before. So we have a high calcium burden of the valve, but we have optimal transfemoral access with the large vessels, so more than 7 millimeters each. We don't have a calcification in the arch and in the LVOT. We selected LOTUS Edge 27 with right femoral access. If you remember, the derived diameter was 25.6. So to explain why in some way we choose that, we already discussed it, but the difference that we have now on our shelves in compared to first, I would like to keep a couple of slides on the difference on the old generation of the LOTUS valve and on the LOTUS Edge catheter. The catheter is more flexible. The valve, you will see, it opens in a different way, so it has more a controlled mechanical expansion. It doesn't scratch or use more the LVOT, has adaptive seal to minimize paravalvular leak, and it is indeed more flexible on the initial side. So the S-curve that you usually do by inserting the device in the femoral artery, it is less than before. In the next slide, you will be able to see the difference for the deployment techniques of these two valves. Now, if you remember very well, the first valve, the LOTUS valve, used to open in the LVOT. We used to look the marker, and then when the valve was completely open, then it used to completely reduce in two directions, and then we used to close the valve. So we had interaction with the LVOT that was quite heavy. Instead, with the LOTUS Edge valve, as you can see on the right, you will see that the valve opens mainly in the aortic side, and the interaction with the LVOT, it is really, really mild. It is only a question of 4 to 5 millimeters. And of course, you know that everybody tends now to put the valve as high as possible. So going back to this case, this is an important question. I will do the question now, and then all the audience will have to think about it. What would you do using now this valve? I told you the valve I used. Would you perform a predilatation with a balloon, an undersized balloon or a normal balloon? Would you use the same valve as we know it is retrievable, recapturable? We can use a mechanical predilatation using the valve per se, or trying to don't make absolutely a predilatation, go for a direct implant with the first go. So this is an important, if you look here, these are the leaflets, the cusp with all the calcium, and I can show you what we have done. Now, this was our first attempt. You can see here, we generally keep the post in a higher position just to don't begin very deep in the ventricle. And you can see here on the right side that when we open the valve into the 3 quarters, you can see that it has like a little banana shape. One side, the non-coronary side, it is a little bit lower than the other side. So we decided to recapture the valve. And this is something that can happen, especially if you have a very calcified, but never matter, because with this valve, as you can see here, we did the second attempt, and you can see now that it's completely symmetrical. And this is the point that we actually try to, the first operator tries to push a little bit more on the out curve of the aorta to help to align the valve properly and help the buccal with the post to close, as you can see here with the valve locked in the right side. And you can see also what I told you before, that the LVOT was really, really little interested, because you can see here that we have around 7 millimeters, 8 millimeters from the beginning. And then when the valve completely closed, you have, if you look at the pigtail, not more than 4 millimeters. And you can see here now the last angio before deciding to go from the no return point. And you can see that the coronary ostia are completely free, and the valve, it's very high because one cusp was nearly 2 millimeters from the end of the valve. And this is the last angio with absolutely, we could say, no leak. And I can swear that the patient had no conduction disturbance, not during the procedure, but even later on. So just to, as I told you, he had very good femoral artery. This is the last shot for the femoral artery. I hope you didn't see it. Can we go back one slide, please, and see if we are able to see it? Otherwise, you will have to believe in me also for the femoral artery. Let's see if we are able to. Okay, well, it doesn't matter. But I would like, in the meantime, that if you are able to see my femoral artery, to ask Wolfgang, what would you have done? I mean, would you decided for a mechanical, let's say, pre-dilatation if this was needed, or you would go with a balloon or an undersized balloon or a normal sized balloon?
Okay. First of all, Sonia, congratulations. I think great case, terrific results, and even if you weren't able to show us the angio, it will be a perfect result. We are convinced about that. So I think we would have done exactly the same because this was a very heavy calcified valve. So we would have used a mechanical expandable valve, such as the LOTUS valve, for sure in this case. And I think with the new design of the catheter and the guide, there's really no need for predilation any longer, even in LOTUS cases. And I think you showed us that nicely. You could even use a repositioning maneuver to predilate the valve. On the other hand, I think the second thing that has to be considered, post-dilation, we heard that is also associated with complications, and I can't recall a single case of a LOTUS implantation where we weren't able to expand the valve properly. So even in this situation, there's no risk of post-dilation when you put in a mechanical expandable valve, and you had complete control over your whole case, no pacemaker. So again, congratulations, and I would have done it exactly the same way.
I'm very pleased to hear so. But I think that it's very important to see the results of the new generation of the LOTUS valve. So Nicholas, please get us through the results of this new device.
Yeah, thank you very much, Anna Sonia. As you mentioned, I think after having seen such beautiful example, it might be interesting to review on a larger number of patients the results of the LOTUS Edge valve since it has been reintroduced to the market. So we are going to discuss here and present the results of a Respond Edge study that is a prospective open-label single-arm post-market registry sponsored by Boston Scientific that is planning to enroll 200 patients at up to 20 European centers. And in the design of this registry, we had scheduled to have an interim analysis after 50 and 100 patient enrollments. That actually happened for the 50 initial patients on last February. Here are the centers that contributed to this initial enrollments, centers that you recognize and that enrolled those patients. But I think what is most interesting is maybe to focus on the study endpoints, the endpoints we chose for the registry that are quite conventional. There is a primary safety endpoint that is 30-day all-cause mortality, primary effectiveness endpoint that is an historical endpoint in the REPRISE program of mean aortic valve pressure gradient at discharge compared to an historical value of 18 millimeter of mercury. But I think most interesting here in this context is to focus also on secondary endpoints, and we think about the pacemaker rate, of course, and valve performance. That are the two main features that we want to learn about with this new technology. The initial 50 patient baseline characteristics, no need to go through all those characteristics, but I've just highlighted few of them. The age, 81 years old, the STS score, just to say that we are describing here TAVI with LOTUS in an intermediate risk population of octogenarians. Important to discuss further outcomes is the rate of a prior pacemaker at the baseline, that is 20%. And relevant to our discussion today, the rate of a severe aortic calcification, that is a qualitative assessment based on CT scan evaluation by the sites, that was 2/3 of the included population in these initial results. The baseline characteristics, I think we can go briefly through that. It's true aortic stenosis with high gradients and 50% of mean ejection fraction. What is interesting is to see the repartition of the different valve size. So you see majority for the 27, but quite balanced repartition of the other sizes. And also relevant to previous presentation and the discussion of today is the rate of cerebral embolic protection utilization in this registry. That is almost 50% for a patient enrolled in the RESPOND page. As expected, I would say, because we know the features and the technical quality and technical features of this device, all of the patients treated as a successful vascular access delivery, deployment of the valve, successful retrieval of a delivery system with only one LOTUS valve implanted, so no need to TAVI in TAVI for the procedures, but this is one of the common known features of a LOTUS valve related to its safety. Happy to see that we did not have mortality before discharge, a 4% rate of stroke, and interesting to know it's two patients actually, one who had a stroke within 72 hours, and this patient did not have cerebral embolic protection used in his procedure, and one stroke that was delayed after 72 hours, and that was a non-disabling stroke. The other commonly described acute clinical outcomes that are the components of the valve safety composite endpoints are quite good and reassuring in this population. As you see, no life-threatening bleeding, 2% major vascular complication, no peri-procedural coronary obstruction, leading to a 6% of valve safety composite endpoints. And the other secondary endpoint, and as I mentioned, we want to focus on one particularly interesting for us, based on the previous outcomes described with a LOTUS valve, that is the permanent pacemaker implantation. So depending on the way you define them, based on the number of pacemaker above all patients, or number of pacemaker above patients only naive from preliminary implanted pacemakers, the rate is varying from 80 to 22.5%. So still, I would say significantly high, but lower than what we knew and what we had with the previous registries, and reminding that we were here talking about 2/3 highly severely calcified valve population in this registry. But I think we'll maybe discuss that later on. As expected, and it has to be mentioned that it's a collab adjudicated data. We have, of course, a perfect and beautiful acute hemodynamic outcome with this valve, with a good relief of the stenosis and a low gradient. And it's important to see that for such intra-annular valve, we have a mean gradient after the procedure that is almost at 10 and no more than 10 millimeter of mercury. And one of the principal and most important features with this valve is the ability to reduce the risk of paravalvular leak. And as expected, we confirm here those results. As you see, with at discharge, no patient having moderate or even a severe PV leak, and only 15% having a mild PV leak. Again, this is collab adjudicated, reinforcing the robustness and the strength of those results. So in conclusion, this is so far a small, in absolute numbers, small cohort of patients reported, but quite robust regarding the design, and one of the first reported with LOTUS Edge. Good safety profile, I would say, no procedural death, no repeat procedures for valve-related dysfunction, a rate of permanent pacemaker implantation varying from 18 to 22.5%. That is better than what we had in the previous registries. And as expected, confirmation of an excellent hemodynamic outcome with this valve and very low PV leak rate, although we treated 74% of very severely calcified valve in this registry. So I think this is the basic and the main features of this new LOTUS Edge valve described in the contemporary practice. And I think maybe unless you have a burning question regarding those results, maybe it's time and we can address some questions of our colleagues who are listening to us, because we have some, I think, really interesting questions related to the case you showed, Anna Sonia, and the topic today. So maybe a first question from our colleague that I would ask to Dan can start from the case presentation, but also can lead to a more general discussion, and is about the membranous septum length measurements. So I think, Anna Sonia, in your case, you did not mention the measurement of this particular anatomical feature. So Dan, is it part of your routine strategy when you're planning a TAVI case? And more importantly, according to this measurement, how do you adapt your strategy?
Yeah, so I think the first thing to say is that you need the CT to be right to measure the membranous septum. So you need a CT that has contrast in the right and the left ventricle at the same time. Sometimes that means a conversation with the radiologist to change the timing of the CT. Once you've got that, then it's pretty straightforward to measure the membranous septum, usually beneath the right coronary cusp or junction of left and right coronary cusps, and looking for the transition from kind of wide to narrow, and that gives you a length of the membranous septum. And what we've seen in some fairly recent studies is that the length of the membranous septum, as we'd expect from our knowledge of the conducting system anatomy, can predict the risk of permanent pacemaker implantation. Essentially, if you can deploy your valve higher and not go below the length of the membranous septum, then you should be able to avoid a pacemaker. And we saw that in the Hassan Jalahawi's work from New York, where they showed that if the membranous septum was long, then you virtually never had a risk of a pacemaker, regardless of depth. If the membranous septum was short, then you had to deploy high to avoid a pacemaker. And I think that's pretty useful, because we know that deploying high with any valve type is not entirely without challenges. And, very rarely, especially with modern technology and really never with LOTUS, but you can get a pop out with other valve types. It should never happen with LOTUS because it's fully repositionable and retrievable. So what we'll do in our cases is measure the membranous septum and then use that to understand the depth we should be targeting if we wish to avoid a pacemaker, and that can be applicable to all valve technologies. I think with LOTUS, we can say that we know the importance from Wolfgang and other people's work of deploying high. We know that we can have a high pacemaker rate if we don't deploy high. So that's where measuring the membranous septum can really tailor the strategy and the target depth.
Okay, thank you very much. Very clear, Dan, and for regarding this issue. Another really interesting question, Wolfgang. You gave us very important and clear information regarding cerebral protection device use. One of our colleagues would like to know if there are any risks associated with the use of those kind of device, and namely here the Sentinel, because you mainly talked about this one.
Okay, I think this is an important issue, and this is very goodly addressed by the initial randomized trials. So there is no harm in putting in that system, and there is no increased stroke rate. This could have happened in the protected patients in comparison to the unprotected patients. So I think this is pretty much answered. And I don't know, I think we did almost 1,000 protection cases so far in Ulm, and we didn't see a single injury or dissection of one of the carotid artery or the trunk. So it's very elegant system, very safe and easy to put in, and I think there shouldn't be any concern of not being able to put the system safely into the patient.
Wolfgang, maybe another short question about the use of this cerebral protection device, and namely the Sentinel. In case you don't have any radial nor ulnar artery suitable, and then you consider that the patient deserves a cerebral protection for your TAVI procedure, do you go for a puncture of a brachial artery, or you try to avoid?
No. We do that routinely. We even have everything prepared because they are usually very old people. And so you might have trouble getting radial access. So everything in the cath lab is already prepared to go for brachial artery access. And this is also basically giving you the same safety regarding puncture complications. So we would always try to get the system in.
Okay, thank you very much. Anna Sonia, another question for a participant to our webinar that feels that, considering all what has been said, he would say that LOTUS would be his first choice in case of bicuspid valve. What are your thoughts on that?
Well, this is a good question and a good subject for the LOTUS valve. It is very particular, the way that we deploy the valve in a bicuspid. So first of all, to have a valve that is retrievable, repositionable, where we can check if we want also the gradient and decide, it can be a very, very good option. Second, we've been using this valve, especially in type 1, and we saw that we are able to decide a good evaluation of the size of the valve with LOTUS without having no necessity in doing a post-dilatation. What is generally done in these cases, we do a pre-dilatation with an undersized balloon like in any other valve. But I think that the LOTUS valve is a very good option for a bicuspid, definitely.
Thank you very much. Another interesting question, and I think, Dan, you partially mentioned that, or it was mentioned, but I would like maybe your input on that. That is, do you post-dilate in LOTUS cases? Is it something that sometimes happen in your experience, or do you consider that regarding the mechanism of this device, it's useless?
Yeah, it's a good question, Nicola. I mean, the first thing to say is that post-dilatation is incredibly rarely required with LOTUS, because the primary indication for post-dilatation is paravalvular leak, which is virtually never seen in any realistic, in any significant number. Secondly, you can address paravalvular leak if you do see it with LOTUS by repositioning and redeploying the valve, which will frequently result in an improved seal and leave you with mild or more likely none or trivial leak. However, there is a small subset of patients in which we have in our centre in Leeds post-dilated, and those are patients with highly hostile anatomy, particularly heavily calcified bicuspid anatomy, in which there's a degree of eccentric frame under expansion after initial deployment, which is associated with residual gradient, something we can see, I think, with all valve types in bicuspid anatomy. Now, if you see that, you have two options essentially. If you recognize it from under expansion of the frame and you measure the gradient on echo, you can then reposition the valve, and that will sometimes fix the problem. But the alternative strategy is to post-dilate, and that post-dilatation is different to the post-dilatation you're doing for paravalvular leak. You can't overexpand the LOTUS valve. You're not trying to make it any bigger. You're just trying to abolish the eccentric under-expansion that may be causing a residual gradient. So you can do that with a very conservatively sized balloon. So when we've done this in Leeds, and I'd say we've done it in about 15 cases over the course of the last 7 years that we've been using LOTUS. We use a balloon that's non-compliant, a True or maybe an Atlas, and we size it 3 millimeters smaller than the valve itself. So that way we know all we're doing is taking out the under expansion, but we shouldn't be threatening any risk of annular rupture or dissection or other complication. And what we've seen is that it's been a very effective strategy in abolishing a gradient, and we've had no adverse complications.
Thank you very much, Dan. And maybe a last short question, because we have many coming from our colleagues. Maybe for you, Wolfgang, we saw I think a paper from your team describing the impact of implant depth, and one of our colleagues would know during your LOTUS cases whether you're implanting in the conventional free-cast view, or if you're going more in aerial, in a cusp overlap view, in order to try to be as high as possible.
Okay, so the data which was shown is basically based on a tricuspid view and more on the LAO side, because with the old LOTUS valve, we were kind of concerned to losing control over the guide, which was very stiff in the early cases. And now with the LOTUS Edge system, I think everything got even more relaxed during the implantation. And we recently switched our strategy and implant now basically more on the RAO side, because I think we are all aware of the data that we are not even able to say clearly if we are 4 or 5 millimeters or 2 millimeters below the annulus, if you measure on the left cusp and then we move to the right or the non-coronary cusp. And I think overall, usually you are lower if you aim to the left coronary cusp than if you would aim to the right or non-coronary. And this is basically the strategy we are just trying out, but we haven't any data yet if this gives us higher implantation.
Thank you very much. And maybe last one that I will comment is just a question about the way we do pre-dilatation in such severely calcified aortic stenosis patients. So I think you will agree, because I think it's our current trend, that in those kind of patients, when we pre-dilate, we use undersized balloon, and that was a question of our colleague through the chat box. Do we undersize balloons? So yes. Practically speaking, if we have an annulus of 23, we use a 20 or 18 millimeter balloon to predilate. So thank you very much for all those questions, and very interesting questions. I think, Sonia, now maybe you can recap this discussion.
Okay, thank you, Nicolas. Yes, I think that we had a really nice and good time, interesting. And I think that we can say now that complex calcified aortic stenosis can be treated with success, and that there are some concerns of paravalvular leak, annulus rupture for these complex anatomies, but we are able to achieve good results if we have good imaging and we can understand and plan our procedure before we get in the cath lab. Another important aspect is the embolic protection. We have underlined that embolic protection now seems terribly important because they seem to reduce the importance of a very, very bad complication. And now that the patients are getting younger, this is a very important issue. So at the end of all, we can say that calcified lesion can be very well performed, and there is an evidence that the LOTUS Edge, it is a very good device that can help in these cases and in others. Thank you for the attention, and goodbye to everybody.
Bye.
Bye.
Bye.